Welcome to the Emergency Medicine Cases podcast. I'm your host, Dr. Anton, bringing you the brightest minds in emergency medicine from around the world. EM Cases is brought to you by SHREMI, the Schwartz-Reisman Emergency Medicine Institute. That's a nonprofit organization dedicated to improving EM care through high-quality research and education. The opinions expressed on this podcast are intended for information and education purposes only and should not be used to diagnose, treat, or prevent any medical condition, nor should they be used as a substitute for medical advice from a qualified practicing physician.
First, just a quick word from our sponsor, Metricade, the experts in complex physician scheduling since 2012. I've been using Metricade's incredible scheduling system for more than a decade, and it's been a game changer for me and my colleagues. Shift work comes with its challenges, but Metricade helps minimize the drawbacks by ensuring fair distribution of shifts while integrating circadian rhythm-friendly recovery time into its methodology, preserving your precious sleep so that you can perform at your best. Go to metricade.com/emcases to see how Metricade can make your scheduling fair, improve your sleep, and your performance. That's metricade.com/emcases.
This episode is brought to you by Paratus, your ultimate assistant for every emergency. Built on the trusted foundation of Easy Resus, Paratus brings you intelligent search, a complete library of procedures and protocols, and Atoms, your assistant to obtain the right information when seconds count. Discover Paratus today at paratusmedical.com/emcases and be ready for anything. A 38-year-old woman storms into your ED with a raging fever, heart rate of 148. That's irregular. She's agitated, drenched in sweat. She's tremulous. And you can see all this from the doorway. Is this sepsis? Is it a sympathomimetic poisoning? Is it alcohol withdrawal? Or is it the great mimicker you don't want to miss, thyrotoxicosis tipping into thyroid storm? Hyperthyroidism is more common than we think, about 1.2% of the population. And when we decompensate, mortality climbs fast if we hesitate. Thyroid storm may be rare, but without treatment, it carries a double-digit mortality. This is the catch. It doesn't always look stormy. Older patients can present apathetic, with fatigue, just AF, a bit of CHF, confusion. In this part 2 of our 2-part episode on thyroid emergencies, I'm so pleased to have back Dr. George Willis, EM Doc, and Dr. Alyssa Louis, intensivist, to sharpen your bedside recognition and first-hour management of hyperthyroidism and thyroid storm. We'll unpack the mimics and how to separate them, plus the atypical elderly presentations that fly under the radar. We'll hit what labs actually help beyond TSH and free T4. We'll also talk about where the scoring systems fit. Most importantly, we'll talk about when to treat on spec with the medications that save lives and talk about the specific sequence of some of these medications, which is very important. You know, there's the beta blockers, there's methimazole or PTU, there's steroids, and there's iodine. We'll cover passive cooling and smart rate control when AF meets heart failure. Thyroid storm is a clinical diagnosis. Delays kill. So let's make sure you spot it, start the right bundle in the right order, and turn the tide before the labs are even back. So welcome back, George, and welcome back, Alyssa.
Thanks for having us.
Wonderful to be here again, Anton.
All right, let's go further into the case that I mentioned in the introduction there. This is a 38-year-old woman who comes storming into your ED with a fever, high fever, shortness of breath, and confusion for the past 2 days. She reports feeling increasingly anxious, sweaty, and unable to sleep, with a recent 2-kilogram weight loss and 1 episode of vomiting. Vitals show a temperature of 39.6 degrees Celsius, a heart rate of 148, and it's irregularly irregular, a blood pressure of 140 on 58, and a respiratory rate of 26. She appears agitated and flushed with a fine tremor and brisk reflexes. All right. So let's start with your general impression. You know, what else do you want to know? Your differential, workup, what medication you might give, just sort of a general overview. George, do you want to start with you?
Sure. So first, obviously, this is someone who's looking very ill. Sounds like she's able to give us a little bit of the history, which is good, but she has some confusion, which means whatever is going on is affecting her mental status. So just starting with vital signs, kind of the global overlook. You have a patient who's febrile, tachycardic, although her tachycardia is more than what I would expect for her level of fever. has a very wide pulse pressure on her blood pressure, and she's tachypnic at 26, which means somebody actually counted it. Most of the time we get 20, but this time it was actually counted. Don't have an oxygen saturation, but she's sweaty, agitated, tremulous. So just looking at the overall picture before I get into the history, I've already come up with a little bit of a differential. This is screaming to me, all things being common, that there is either some type of intoxicant on board, or she's withdrawing for something, or sepsis. In the absence of any history of substance abuse, endocrine nerd aside, it is sepsis until proven otherwise, including encephalitis, meningitis until proven otherwise. And then depending on if she's on any medications at all at home, regular medications, therapeutic or iatrogenic medications, if you will, you got to consider the other toxidromes such as serotonin syndrome, anticholinergic, although less likely. And then that endocrine nerd in me would want to see, is her sugar low? Is she hypoglycemic? Or is her thyroid going haywire? And then in terms of interventions at this point in time, I'm going to start with some acetaminophen for her fever, some IV fluids while I'm waiting on those labs to come back. Some people really preach about early antibiotics and sepsis, but that's primarily for severe sepsis or septic shock. I don't really think we've reached that category yet because we don't really have, a person who is severely hypotensive or even hypotensive. I'm sure they're tachycardic, but I don't think we're at the point where we're going to say we're going to start antibiotics right off the bat. But I'd get those sepsis labs and work up in this initial phase.
Fantastic. Alyssa, what's your take on this case?
Yeah. As George mentioned, there's a pretty broad differential here. I just want to also say, in addition to the general kind of septic presentation, meningoencephalitis is something that's also pinging up here and should be on the differential for a patient presenting this way. So I'm definitely getting a broad panel of general labs here, but also getting our thyroid studies with their TSH obviously cooking. I'm going to be getting an ECG to look for tachyarrhythmias, a CK to look for rhabdo, urine drug screen, CT head, general blood urine cultures, viral studies, and then depending on the above in her presentation, I might also do a lumbar puncture just to be making sure that we're not missing any type of CNS infection here. And then 100% never going to forget it or do my best not to is this patient needs a pregnancy test, not only for working up the underlying etiology, but also to subsequently guide our therapeutics once we've made a diagnosis.
All right, so putting this all together, it's sepsis, and great point about, meningitis or encephalitis should be up there when it comes to the sepsis part. We want to be thinking about toxidrome as well. I guess the other possibility would be environmental hyperthermia, something you want to consider if you live like George does in Texas. It happens in where Alyssa and I are in Toronto occasionally in the middle of summer, but not too often. I'm sure you see more hyperthermia cases than we do. We're going to talk about some of the other clues in here that make you think hyperthyroidism. Let's get into the challenging presentations of thyrotoxicosis and thyroid storm. In a patient like this with fever, tachycardia, and altered mental status, how do we tease apart thyrotoxicosis from sepsis, sympathomimetic toxicity, or anticholinergic syndrome? What's your clinical approach to this great mimicker of thyrotoxicosis? Dr. Willis?
So a lot of endocrine diseases present to the emergency department with usually non-compliant with their medications. And so when you have a patient with a history of hyperthyroidism who may be not compliant with their medications, if that was the case, this would be easy. And wouldn't that be an awesome world to live in? Unfortunately, the reality is that up to 43% of patients hospitalized with thyroid storm have undiagnosed hyperthyroidism. So we may be making the diagnosis of hyperthyroidism in the emergency department. And this diagnosis, unfortunately, is not easy. The thyroid is called the great mimicker for a reason. I like to call it the syphilis of endocrine diseases because it can present like anything. It looks like a lot of things that we oftentimes are going to see more commonly in the emergency department. And so we really have to keep a good differential diagnosis on our mind and think about the thyroid in these very, very sick patients. So in terms of how to differentiate, the history and physical exam is what to harp on at the beginning. So starting with the history, obviously you're going to focus primarily on Does this patient have any other potential medications that can induce these very similar symptoms to thyroid storm or thyrotoxicosis? So any recent additional medications that the patient may have been started on, such as anticholinergics, serotonin, SSRIs for serotonin syndrome, are certainly going to increase these patients for having risk for anticholinergic toxicity or serotonin syndrome. Substance abuse history for possible intoxication versus withdrawal from some type of substance. If none of that is true, if the patient is a relatively healthy, never been to the doctor, not on any medications, and you have a pretty good, reliable history that there's no substance abuse on board, start thinking about the thyroid. You're going to ask about some specific thyrotoxicosis symptoms, such as unintentional weight loss, temperature intolerance, unexplained diaphoresis, any psychomotor agitation, restlessness, decreased sleep, gastrointestinal distress, nausea, vomiting, diarrhea. And then on your physical exam, your vital signs are going to be a little bit helpful in this scenario as well. So you're going to have potentially fever and tachycardia, which can be present in sepsis. But as I alluded to earlier, with thyroid storm, traditionally you're going to see a tachycardia that is disproportionately higher with respect to the fever. So in this patient, she has a temperature of 39.2, but their heart rate is close to 150. Why is their heart rate so high compared to the fever that's present? Also, that widened pulse pressure. There are only a few things that give you a widened pulse pressure. Atherosclerosis and hardened arteries is one of those reasons, but in a 38-year-old female, that's very uncommon. And so anything that causes high output heart failure can give you a widened pulse pressure, and thyrotoxicosis can certainly do that. Next, you're going to actually look at the patient. Look at the eyes. Is there any evidence that the patient has proptosis or exophthalmos? And then what do the pupils look like? Because that may give you a sense, does this patient have a toxidrome or some type of withdrawal scenario with some pathomimetics and anticholinergics giving mydriasis. Look at the mouth. Do they have tongue fasciculations? Alcohol withdrawal can give you tongue fasciculations, but actually thyroid storm in certain circumstances can also give you tongue fasciculations. But look at their mucous membranes. Is their mouth dry? More commonly in sympathomimetics and anticholinergic toxidromes, you're going to have a dry mouth. Look at the neck for presence of a goiter. Lungs, you may have some rales, which are consistent with pulmonary edema. Heart may give you an irregular rhythm or just may be tachycardic. And then the abdominal exam may give you some right upper quadrant tenderness, which can happen with thyroid storm. If they have bladder fullness or distension, think anticholinergic toxidrome. And then you're going to look at the skin. Are they diaphoretic, more consistent with thyroid storm or thyrotoxicosis versus dry skin, which you're going to see more commonly with your anticholinergic toxidromes. And then you got to do a good neuro exam. Specifically, you're going to also make sure that you're not forgetting those reflexes. Serotonin syndrome, thyroid storm is more commonly going to give you hyperreflexia, but serotonin syndrome is going to give you clonus, which is rare in thyroid storm and thyrotoxicosis. So the history and physical is going to kind of help in terms of figuring out, does this patient have something that's more commonly going to be seen in a toxidrome or serotonin syndrome or anticholinergic toxicity versus is that thyroid going to be acting up? And in the absence of any medications or substance abuse, you're going to be leaning more towards thinking about that thyroid.
Wow, that was an incredibly thorough answer. There's so much stuff to unpack there. We'll get to unpacking that, I think, later in the podcast. To sort of tease it apart in sort of a 1-minute thing, I kind of think of it as dry versus sweaty or diaphoretic. You know, if they're dry with the retention, you're thinking anticholinergic. Like you said, if there's clonus, think serotonin. If there's any alcohol history at all or history of seizures, think alcohol withdrawal. And if there's sort of a new stubborn AFib or sepsis without a source that you can't figure out, then that's sort of when we should be moving on to thinking about thyrotoxicosis at the top of our list and maybe even starting medications. Alyssa, any thoughts on teasing out thyrotoxicosis from the rest of the differential?
Yeah, I think that a lot of really important points have already been hit there. I did want to mention one thing about how thyrotoxicosis doesn't always present in classic ways, particularly in the elderly, which can make a tricky diagnosis even more tricky to catch. There's such thing as so-called apathetic thyrotoxicosis or masked hyperthyroidism. In the elderly population can present with fatigue, weight loss, AFib, tachycardia, congestive heart failure, confusion, and it can totally lack the hyperactivity or fever that we usually hang our hat on when we're coming to this diagnosis or adding it to our differential. So think of sending your thyroid studies even in atypical presentations if some things are just not adding up.
So we really need to be on the lookout for apathetic hyperthyroidism or thyrotoxicosis. And we should really consider that in the elderly and those with subtle or atypical presentations. I guess some of the red flags are an older patient with new AFib that's hard to control. Again, sepsis without a source, or if they have, CHF that seems to be out of proportion to the rest of their history. Those are some of the red flags where we can think about apathetic thyrotoxicosis. And then I guess some of the big things is, normally in thyrotoxicosis, they're agitated and they have a tremor, and those might be absent in these patients. I mean, we see so many patients that are older with fatigue and maybe some weight loss and maybe AFib, maybe some CHF or a fever that we can't really figure out. But we should definitely add apathetic thyrotoxicosis to the differential in these sorts of patients. George, any additional comments about apathetic thyrotoxicosis?
It's interesting. I've caught 3 of these in my career.
Wow.
And in all 3
Impressive.
of those circumstances, what it was in just about every one of those scenarios, none of them were patients that I was suspicious of apathetic thyrotoxicosis. I just want to throw that out there. It may seem like something that I would certainly catch being an endocrine nerd, but it is not an easy diagnosis to make. In all 3 of those circumstances, I was checking a TSH actually for the other reason. The patients were complaining that they were fatigued, they were very run down. And in my differential, I was thinking, maybe this patient is anemic, maybe they have new onset heart failure because of their heart's just, tired. And, maybe they have sepsis or a urinary tract infection, and that's what's causing them to be a little bit more on the fatigued and run down side. And so I got a TSH primarily looking for maybe they have new undiagnosed hypothyroidism, and then was massively surprised by the fact that their TSH was actually low. And we have at our lab, we have a TSH with a reflex T4. Free T4. So when the TSH comes back abnormal, the lab reflexively sends a free T4. So I got the TSH and the free T4 back at the same time and was massively surprised that these patients had low TSHs with elevated free T4s and said, oh. And of course, my residents were all like, Dr. Willis, I can't believe that you thought of that. And I was like, yeah, I know.
Nice pickups. Okay, so we've talked a bit about the typical presentations and the atypical presentations. I think there's actually some other presentations that thyrotoxicosis might come in with. Can you guys comment on any other presentations? There's one that I've seen before where someone comes in with anterior neck pain and they end up having thyroiditis. And sometimes that gets confused, just with like a pharyngitis or some other much more common cause of neck pain. Any other presentations that you want to highlight, George?
Sure. So any new onset atrial fibrillation with rapid ventricular response that especially doesn't respond to rate control measures, I always preach to my residents that any new onset AFib with a fever, you should 100% be thinking, does this person have thyrotoxicosis? Then any patient who looks like sepsis without a clear source should be considered for thyrotoxicosis. And this is actually a little bit more on the difficult side, right? We get a urinalysis, we get a chest x-ray. If they have abdominal pain, we may even do things like a CT scan of the abdomen and pelvis looking for any types of intra-abdominal source of infection. But blood cultures take days to come back. And then don't assume that a patient with a fever without any other source of infection, don't just say, oh, well, this patient probably just has undiagnosed bacteremia, so I'll just start them on antibiotics admit them to the hospital, let the hospitalist wait on the blood cultures to come back for their probable diagnosis. The TSH is something that you can send that can make sure that this now fever without a source, maybe that's due to this patient having thyrotoxicosis. So if you don't have a good source and the patient doesn't have any symptoms of any infectious etiology, send that TSH to make sure that you're not missing anything that's related to the thyroid. And then, as you alluded to, any patient with anterior neck pain with symptoms of thyrotoxicosis, certainly we should be thinking, could this be thyroiditis, which can induce thyrotoxicosis? And I've caught a couple of these with patients that most of these just had thyroiditis. So I've caught a couple of thyroiditis in my career. But those patients came in with sore throat. And then I looked in their throat and there was no pharyngeal erythema. There were no exudates. And I said, why does this person have a sore throat with a fever? And most of the time, they say it hurts when they swallow. They have some odynophagia. And then you may palpate their throat thinking, well, let's just make sure there's no neck infection, such as a skin infection, a soft tissue skin infection. And then they say, ow, that really, really hurts. But there's no erythema. There's no warmth to suggest a soft tissue skin infection. Maybe it's the thyroid. And so those patients, I get a TSH and a free T4 full on as well. And sometimes you'll get some elevation with that. And you can see thyroiditis with that as well.
Yeah, that's a great one. Normally when you see fever and sore throat and the pharynx looks totally clear, you think epiglottitis is the first thing I think of. But just adding to that thyroiditis and just palpate the anterior neck, I think that's a great clinical pearl. All right, any other presentations we should be on the lookout for? So we've talked about, rapid AFib that's not responding. We've talked about sepsis without a source. We talked about thyroiditis. Anything else?
So the only other one to consider is that if you have a patient, and this is a hard one, this is a really hard one. I have actually never seen this in my career, which means I probably have missed this in my career. So if you have a patient with thyrotoxicosis features, maybe have a headache, but they also have some vision changes, maybe bitemporal hemianopsia, and you're thinking, why does this person have bitemporal hemianopsia? Maybe they have some kind of brain mass or something like that. You have to think about, could this be secondary hyperthyroidism or thyrotoxicosis? So that patient usually has a pituitary adenoma. And in that scenario, a lot of times this can be difficult to diagnose, even with a CT scan of the head, because if the pituitary adenoma is small, you may not diagnose it. So you may get a CT scan of the head looking for the potential cause of the bitemporal hemianopsia. In order to actually make this diagnosis in most circumstances, you have to get an MRI, and that's not something that we frequently will get in the emergency department. But if you get some other screening labs for pituitary adenoma, maybe this person has, when you get the TSH and the free T4, it's actually going to have an elevated TSH as opposed to a low TSH. And in this scenario with a patient who has symptoms and signs and symptoms of thyrotoxicosis, if they have an elevated TSH, that almost seals the diagnosis that this person probably has secondary hyperthyroidism.
All right. It's not hard enough that there's apathetic thyrotoxicosis, but there's all this secondary thyrotoxicosis from a pituitary adenoma. Anyhow, it's all very interesting, actually, just what the possibilities are. And that's a great pearl in terms of if your TSH is high and your T4 is high, then think about pituitary adenoma, especially if they, have headache and bitemporal hemianopsia. And now a message from one of our sponsors. Are you an emergency physician looking for an exciting opportunity? Cornwall Hospital is hiring motivated ER docs to join their dynamic team. With over 50,000 visits a year, you'll see a wide variety of pathologies in a fast-paced, supportive environment. Your colleagues and consultants are always ready and willing to back you up. Cornwall, Ontario is a hidden gem on the St. Lawrence River, offering waterfront access, outdoor activities, and a small city charm. All within an hour's drive from Ottawa and Montreal. Join their family at Cornwall Community Hospital, and once you're there, you'll never look back. For more information, please visit www.cornwallhospital.ca and click on Join Our Team, Physician Recruitment, or call 613-938-4240, extension 2227. I want to move on to a bit of pathophysiology before we get to our management of these patients. because we can't really understand why we're giving all these medications unless we understand the pathophysiology first. So, Alyssa, what do we need to understand about the pathophysiology of thyrotoxicosis and thyroid storm to help us inform our decision-making in the emergency department and manage these patients well?
I don't want to get too deep into the weeds here, but one of the things that I find really interesting is it's actually the rate of the rise in the thyroid hormone levels rather than the absolute values that contribute to the development of thyroid storm. And there's also a big role of tissue sensitization and sympathetic dysregulation that are key elements here to this presentation. So, without getting into too much detail, it all starts in the hypothalamus, which releases thyrotropin-releasing hormone, also called TRH, that tells the pituitary gland to send out TSH, thyroid-stimulating hormone, which then acts on the gland itself to kick off the production of T3 and T4. Inside the thyroid, iodine gets pulled into the follicular cells, where an enzyme called TPO, thyroid peroxidase, sticks it onto the thyroglobulins. And these are the iodinated building blocks that combine to form T3 and T4. Now, here's one of the key messages, is that T3 is the more potent and active form of the hormone, and most of it is actually made by converting T4 in the periphery, which is a key hinge point for our therapeutics that we're going to talk about during the management component. And what do these hormones do? We can think about it both in terms of what they're supposed to do physiologically, but also what happens when things go off the rails. So in normal physiology, it boosts beta receptors in the heart, increases cardiac output, heart rate, and contractility. And in the lungs, it'll improve your oxygenation through supportive respiratory muscle function, promoting ventilatory drive. So this operates as well on a negative feedback loop. So when T3 and T4 levels are low, the hypothalamus will promote further excretion and ramp things up. And then conversely, usually what's supposed to happen is that when levels are high, they'll dial it back, kick in, and drop synthesis. So when there's an issue with the system, whether it's revving up too high or if it's bottoming out, the effects can be quite massive and multi-system.
All right, so a key point there is recognizing that it's really the speed of acceleration plus the tissue response that is what destabilizes patients. And that kind of helps explain both the protein presentations and why our medication bundle works the way it does, which we're going to get to soon. Okay, so that's a bit about the pathophysiology. We're about to get to the medications, but before we do, I want to talk just briefly about the scoring systems. So the scoring systems can help us decide whether we actually have the diagnosis or not, which will help inform whether we should start the medications or not. Because as we were alluding to before, thyrotoxicosis is a clinical diagnosis, and we may be actually starting the medications before we even get the T4 back. I had mentioned at the top that there's the Birch-Wartofsky point scale, and there's the Japan Thyroid Association criteria. Alyssa, any value in these? Is it like every other decision tool in emergency medicine where it's good to know the points because we want to cover them in our history and physical? It's not going to give us the exact answer every time, but they're kind of good to know. How about these scales? What do you think?
It's useful depending on how you use them. There are differences between the two scoring scales. So first up, the Birch-Wartofsky point scale, also called the BWPS. It's an old one. It was designed to help clinicians distinguish severe thyrotoxicosis and full-blown thyroid storm based on a point system that covers their thermoregulatory, cardiovascular, GI, CNS, and precipitating factors. So pretty much you get points if you're hyperthermic, tachycardic, if you've got adjunctive symptoms like agitation, delirium, or coma, and then the additional features such as congestive heart failure, atrial fibrillation, GI symptoms, and whether or not there's a known precipitant like infection, surgery, or missed medications. So the higher the score, and certainly above a threshold of 45, strongly suggests thyroid storm, whereas the lower scores, you might be classified within the impending storm zone, and if you score less than 25, it argues against it. So it's an unvalidated data set that helped derive to this, and it can definitely overcall thyroid storm. So if you were to apply this points system to every person who comes into the emergency department, with sepsis, altered mentation, and atrial fibrillation, which is the bread and butter of my referrals to the ICU, you're definitely going to overcall it. In contrast, there's the Japanese Thyroid Association criteria for thyrotoxicosis, which is more up to date, and it's more binary and strict, and also includes lab values to classify patients into two categories, which are either definite thyroid storm or suspected but unconfirmed or not meeting full criteria thyroid storm. And the use of objective biochemical thyrotoxicosis is really helpful here because this is what helps distinguish, an undifferentiated, hot, sweaty, atrial fibrillation patient from someone who has full-blown thyroid storm. And so the way that I would use this is they both have, clinical areas of utility. If you're suspecting a diagnosis of thyroid storm and you're looking for an excuse to start your patient on antithyroid medications in the appropriate bundle, go ahead and use the Birch-Wartowski system because it'll raise your clinical suspicion and help you kind of push your diagnosis to get things started. And you certainly don't want to delay therapy, but the Japanese Thyroid Association scoring system is definitely more specific. Regardless, these are helpful scoring systems, but they don't replace clinical judgment. So if your patient is scoring but has a clear alternative diagnosis, this is not going to be a helpful system for you. However, if your patient is relatively undifferentiated and you're trying to figure out, do I really think that this patient should be treated as thyroid storm, go ahead and use it to help you make that decision.
Fantastic. Fair enough. So now we've got a probable diagnosis of thyrotoxicosis. Just like in decompensated hypothyroidism that we talked about in part 1, sometimes we're going to treat these patients on spec before we get the TSH and T4 back, which in some centers takes forever. So, George, in what situation would you treat for thyroid storm on spec before the labs get back?
So if you have a high clinical suspicion, obviously a patient who has known hyperthyroidism, who's been non-compliant on their medications, that's certainly going to be a scenario where you're going to think about treating thyroid storm in this patient population. But if there's things that kind of allude to the fact that this patient may have severe untreated hyperthyroidism. So if they're severely hyperthermic and they are altered, that's certainly a patient that you may think about, could this patient have undiagnosed hyperthyroidism, and start the treatment. Again, we come back to the patient with atrial fibrillation that's difficult to control their rapid ventricular response with the usual measures. That's a patient that you certainly want to think about. Could this patient have undiagnosed hyperthyroidism? A patient who has an obvious goiter with signs and symptoms of hyperthyroidism, that's a person who you probably want to treat as well. And then we talked about that high output heart failure. There's only a few things that cause high output heart failure. So there's some vitamin deficiencies that can cause this, anemia that can cause this. If their H&H is fine and they don't look significantly malnourished, that's a person who may have undiagnosed hyperthyroidism as well. And so in this scenario, you're going to initiate empiric therapy potentially before the lab's result, especially if you don't have a rapid turnaround on your TSH. My lab takes about 2 hours to come back. But in a patient who's clinically decompensating, it's reasonable to start empiric therapy, which we'll get into very shortly. A lot of people, and I'm one of those people who think thyroid storm is a clinical diagnosis, and we certainly know that delayed treatments can worsen outcomes. And so this is not a scenario where you're going to wait on that TSH to come back. So in this scenario where you have a hyperthermic, profoundly tachycardic, atrial fibrillation with difficulty to control with signs of agitation and confusion, that's enough to go ahead and treat on spec. You can also use your Birch-Wartowski scale. The Birch-Wartowski scale predominantly uses clinical data that comes back in a relatively quick fashion. So vital signs are going to be very easy to get within seconds. Use some of your very easy to get labs like your CBC, your complete metabolic panel. And in those scenarios, if you have a patient who meets a very elevated Birch-Wartowski score, who you certainly have a high clinical suspicion, completely reasonable, especially if you're not going to get your labs back in a timely fashion, to go ahead and start empiric treatment. So crashing, altered, hypermetabolic patient, thyroid storms on your differential, go ahead and start your treatment in those patients, all in the right order, even before the labs are back.
In addition to getting your T3 and T4, which I understand and appreciate might not come back all that quickly, depending on where you're working. So the TSH being abnormal one direction or the other is a big clue here. So regardless of whether it's elevated or suppressed with the correct clinical syndrome, I think that would be enough for me to go ahead and treat also. And I did also want to touch on some of the other lab values that can be helpful and supportive here. In addition to the TSH and T4, which are usually the bundled, as George said, labs that come back, the TSH is abnormal, you get the T4. I'd also order a T3 here, which can oftentimes be disproportionately elevated in thyroid storm. I'm also going to get a calcium level. General blood work for a critically ill patient will always include electrolytes, CBCs, liver enzymes, etc. But specifically, the calcium can be elevated due to the increased bone turnover, which can also lead to altered mentation and arrhythmias. I'm definitely going to get liver enzymes here, not only just to look for evidence of liver injury in the setting of thyrotoxicosis, but also because I'm going to avoid PTU if there's already a hepatocellular liver injury. So that's important information for me to have up front while I'm making the diagnosis. I also want to get a cortisol. Almost half of these patients will either have overt adrenal insufficiency or relative, meaning that their cortisol levels are borderline kind of low-ish, but still in the normal range. And I'm still going to stress dose them, even if it's kind of flagging as quote-unquote normal. In addition to that, I also definitely want to get an ECG troponins, a BNP, and do a PoCUS, because if my patient is in severely decompensated heart failure with barely any forward flow, I'm not going to slam them with beta blockers, because this can tip them into cardiogenic shock. And your patient definitely won't thank you for this, and neither will your regional ECMO center. As I said earlier, always a pregnancy test, and then some of the other blood work that I would send, to rule out additional septic or toxicologic etiologies, and depending on the clinical circumstance, as we mentioned before, an LP. In terms of sorting out their hyperthyroid state, so once I've got enough evidence to kind of go down that diagnostic pathway and start closing some of the alternative doors, some additional blood work that can be helpful. And, honestly, is it critical to be sending this in the emergency department? No. Will it be helpful for the endocrinologist who's advising and helping, pick up the case, or the internist or the intensivist? Yes, potentially. But, this is by no means a need to send right now. This is a nice to send. In terms of working up their hyperthyroid state, you could also consider sending their thyroid receptor antibodies, because the majority of these patients have underlying Graves' disease. You could also consider sending a thyroglobulin, especially if there's concern about exogenous thyroid supplementation ingestion as a cause of the thyrotoxicosis, because we would expect thyroglobulin levels to be quite suppressed if someone was exogenously taking too much hormone supplement. So pretty much the bottom line, just to summarize, think beyond just your TSH and T4. If you're suspecting thyroid storm, also get a T3, get a full panel of blood work, including the extended lights and the LFTs, and do not forget to get a cortisol, and do not forget to do a cardiac workup. They're not just supportive data. They'll guide both your diagnosis and your treatment decisions.
Let's take a little break to hear from one of our sponsors, Metricade, the experts in complex physician scheduling since 2012. Metricade's expert schedulers are their secret sauce. These people truly understand the complexities of physician scheduling. They empower us by providing the tools we need to manage our teams efficiently. At the same time, they give physicians more freedom to share their workflow preferences, so schedules aren't just fair, they're actually workable. Metricade's system is built to make your schedule work for you. They take the stress out of shift planning so that you can focus on what matters most. Go to metricade.com/emcases to learn more about how smarter scheduling can work for you. That's metricade, one word, .com/EMCASES.
So far in the podcast, we've covered how to recognize this tricky diagnosis. We've talked about how to actually make the diagnosis and use the scoring systems to help us. We've talked about the differential and how to differentiate thyrotoxicosis from all these other diagnoses. We've talked a bit about the pathophysiology and what labs to send off. We're finally now getting to the management, which we've touched on little bits, but I want to kind of really hone in on the management and the medications. These thyroid storm patients, they need cardiovascular stabilization, they need beta blockers, they need steroids, they need thionamides, they need iodine, as well as treatment for hyperthermia and agitation. So let's break all these down one by one. So first, George, what do you suggest in terms of cardiovascular stabilization in the tachycardic, hypermetabolic, hyperthermic, altered thyroid storm patient?
So the thyroid storm kills by cooking the cardiovascular system. And the way I like to think about this is the cardiovascular system drives the train. So if the cardiovascular system gets derailed, everything else just goes more haywire and decompensates relatively quickly. And that's what kills these patients. So our resuscitation priorities hinge on rate control, maximizing perfusion to the rest of the body, and oxygen delivery, all while we're blocking new hormone synthesis in the background. So the kind of bedside sequence that I use, most of these patients, we're going to focus on their ABCs. Most of them are able to protect their airway, but they may have an element of hypoxia, especially in the setting of heart failure from their thyrotoxicosis. So the goal here is to maintain normoxia. Don't jump to intubate these patients. The vast majority of these people don't need intubation. They may be a difficult intubation at that, primarily, especially if they have a goiter that may compress the airway, making intubation very difficult. So if they can tolerate, most of them can tolerate high flow nasal cannula if they need oxygen supplementation. And then if they can tolerate it, now remember, you have a hyperagitated patient. Normal patients have difficulty with non-invasive Boston pressure ventilation. So if you put a BiPAP mask on a hyperagitated patient, it's going to probably lead to a mess. But if they can tolerate it and they need that non-invasive positive pressure ventilation, especially in the setting of heart failure, certainly this should be something that we utilize. Next, I always assess their EF, and I love that Alyssa brought up PoCUS. I'm not going to be able to tell the difference between an EF of 20 and 25%, but I can tell the difference grossly between a hyperdynamic heart and one where there is poor squeeze. So the reason I want to know this is to see which way I'm going with beta-blockade. There are several case reports of patients with low output heart failure in thyroid storm getting even a single dose of propranolol and going into cardiac arrest that is refractory. They end up dying as a result. I don't want to do that. So I use the ultrasound to echo the heart and estimate what their squeeze looks like. Once I see that, I initiate systemic blockade. As Dr. Louis alluded, thyroid hormone increases beta receptor expression, so beta blockade is going to be my go-to to help in this scenario of these patients. We all learn in our professional schools that propranolol decreases the conversion of T4 to the more active T3. Well, we also just talked about how dangerous it can be to just throw propranolol at every patient with thyroid storm. So truthfully, most beta blockers have some degree of decreasing T4 to T3 conversion. It's just propranolol does it the best. So esmolol is usually my go-to in most patients with thyroid storm. It's wrap it on, wrap it off. So if the patient's cardiac squeeze looks depressed, I may give them a trial of esmolol and see how they do. If they start to decompensate, I turn it off, and then it's out of the system a few minutes later. If their squeeze is okay, esmolol works great in this patient population. And if they have a hyperdynamic heart and their blood pressure is not hypotensive, then I can give propranolol in this patient scenario. The goal here is to get their heart rate down less than 110, especially in the setting of high output heart failure. Their heart is beating so fast and so hard that the cardiac output is backing up into the pulmonary vasculature, causing pulmonary edema. By slowing the heart rate down, the cardiac output has time to allow better forward flow. And then IV fluids, completely fine to give to most patients with thyroid storm, remembering that these patients are hypermetabolic, so they're going to have an increased volume demand, and they're going to be relatively volume down. So I usually start with about 1 liter and then reassess in patients who have no signs of low output heart failure. Those are the patients that I'm going to be a little bit more careful with my IV fluids because I don't want to obviously volume overload them, especially if they're already showing signs of volume overload. So if they have low output heart failure, you may actually have to diurese these patients to help mobilize the pulmonary edema to prevent these patients from getting worse. My goals for this first stage of management are going to be the following. 1, I want to get their heart rate less than 110 while maintaining adequate perfusion. I want to, 2, keep that mean arterial pressure greater than 65 millimeters of water. And then I want to ensure lactate is decreasing, make sure that they are maintaining good urine output, while also maintaining normoxia with supplemental oxygenation, whether that be just with regular nasal cannula, potentially increasing to high flow nasal cannula, and again, potentially increasing to non-invasive positive pressure ventilation if necessary. And then once all of those boxes are ticked, I'm out of the immediate danger zone. I can now focus on the rest of the medications, the thyroid storm bundle, if you will, your anti-thyroid medications, your iodine, your steroids. Take-home pearl here being, think of thyroid storm like a runaway train. You want to slam the brakes quickly with a reversible beta blocker, stabilize the tracks with your fluids, potentially if you need to diurese, and then cool the engine with the rest of the therapy.
All right, fantastic. So tons of stuff there. Again, just the goals are a heart rate of 110 or less, a MAP greater than 65, normal oxygenation. I want to talk a little bit more about the sequence of medications. So Alyssa, can you walk through for us the optimal order and timing of the beta blockers, the antithyroid medications, and the iodine, and why getting it wrong can actually worsen the storm? My understanding is that one common mistake in thyroid storm management is giving the iodine too early. How does this all work, and what should we know about when and how to give the medications?
Yeah, thanks for asking. This is such an important point, and I'm really glad that you brought it up. We generally give the beta blocker if the patient can tolerate it, and their thionamide and their steroid up front, and then we have to wait an hour, and then we give them their iodine load. The reason why we give their iodine load later is because if we give it before the antithyroid meds take effect, we can actually worsen their thyroid hormone synthesis. Essentially, you're throwing fuel into the fire by adding a ton of iodine, which is, as we said earlier in the physiology portion, this is the substrate for thyroid hormone synthesis. So essentially, if you're giving it before the thyroid is effectively blocked by their antithyroid medications, they're going to take it up and start pumping out thyroid hormone, which is the opposite of what we want to do in this situation. You have to allow sufficient time for your antithyroid meds like your methimazole or your PTU, at least an hour before you give them their iodine load. So there's a helpful mnemonic so that we don't forget the components of therapy here, as well as the order that we should be giving them in. So it's B-B-sit. The first B is for beta blocker. This is for adrenergic control, so either esmolol or propranolol, assuming that the patient's cardiac function is sufficient for that, in addition to help with the peripheral conversion of T4 to T3. The second B is for block hormone synthesis, so these are blockers methimazole or PTU. The S is for steroids, so hydrocortisone to treat adrenal insufficiency, as well as to reduce the T4 to T3 conversion, so there's a dual effect there. The I is for iodine. So again, we are waiting at least 1 hour after the thionamide administration. And the reason for the iodine is to block hormone release. The last letter is T for treat the underlying trigger. For example, patients with underlying thyroid disease might be tipped into thyroid storm by an infection. So just not to forget potential triggers here that should be concurrently managed. And honestly, the most important part of this order is just making sure that you give your antithyroid medication an hour before giving the iodine. The rest of those medications can be given concurrently.
All right, got it. So I love that. So BB-sit for the medications, plus reminding you to treat the trigger. And again, the bottom line is just making sure that you wait at least an hour to give that iodine. The rest of the medications don't really matter what order you give them in. I want to dig a little bit more into the medications that block hormone synthesis. So there's methimazole and there's PTU. How do you decide which one to use? What are the advantages, disadvantages? For emergency doctors, is there just one that we should use and forget about the other one? Or is there some other way to decide whether to use methimazole or PTU?
They're slightly different drugs. Both of them are very good antithyroid medications, but we're going to choose them based on your patient population and some of their organ dysfunctions. So methimazole, it's got a longer half-life. You don't have to dose it as frequently, so only every 12 or 24 hours, whereas PTU has a shorter half-life, so we have to give it Q8. PTU does have some additional inhibition of T4 to T3 conversion that methimazole lacks. PTU should be avoided in liver disease, whereas liver toxicity is less likely with methimazole. And then if your patient is pregnant, methimazole should be avoided in the first trimester, whereas PTU is safer. So doing a side-by-side comparison, both are great antithyroid drugs, but in my critically ill patient population, I'm usually reaching for the PTU, unless the patient has concurrent liver injury or underlying liver disease, because the drop in the peripheral T3 levels is faster and more robust compared to methimazole.
All right, so that makes it a bit easier for us. Excellent. So we had mentioned that iodine you want to give at least an hour after your other medications. Besides that, anything else we need to know about giving iodine?
Yeah, for sure. And first off, I just want to acknowledge that it seems a bit counterintuitive to be giving a large load of iodine to a patient who's overproducing thyroid hormone, because as we said, it's a substrate for production. And it's like, why are we adding this fuel to the fire? And the reason is because it actually helps block the release of pre-stored T3 and T4 from the thyroid gland, which is something called the plumber effect. It also causes temporary inhibition of thyroid hormone synthesis, which is called the Wolff-Chaikoff effect. So the timing is we want to give it at least 60 minutes after our antithyroid medication to avoid hormone surge, and it needs to be dosed every 6 hours or it loses its effect. Some of the situations where we'd avoid giving it are in amiodarone thyrotoxicosis, because there's already a ton of iodine around from the amio, so giving more is not going to be super helpful here. Another situation is the intoxic multinodular goiter, because they tend to function autonomously without the usual iodide break of the Wolff-Chaikoff effect. So just a couple of cautions there. The other word of caution that I have is that although many of the clinicians who have treated this condition before were always really aware that it's important to give the antithyroid drugs, an hour before the pharmacologic iodine, but it's really easy to forget that there's iodine in a lot of other stuff that our patients might get exposed to during their initial resuscitation. For example, these patients often present with AFib, and we can't forget that amiodarone, which we do sometimes reach for in non-thyroid storm-related AFib, has a very large iodine load. So if this is going to be used, we'd want to avoid giving it until they've gotten their antithyroid meds for at least an hour. And that's why we're reaching for the beta blockers as well. The other thing to remember, there is a ton of iodine in our normal CT contrast, orders of magnitude, like over 50 times more than what we would give in our pharmacologic iodine load for this condition. So we need to be really careful about this too. Admittedly, I scan a lot of my patients, and it's pretty rare for me to bring someone up to the unit without a stop in the CT scanner, especially if they've got altered mentation or some other systemic symptoms. However, this is one situation where I would wait unless it's a truly right now life or brain threatening emergency, like I'm calling a code stroke. The other thing I did want to mention, very minor point about the iodine, is some patients can't get iodine due to intolerances or allergies. Maybe they've been, on this ride before and have had a problem, or, maybe their etiology of hyperthyroidism is due to iodine overload or amiodarone toxicity. There's an alternative. You could also consider use of lithium. I haven't personally had to do this. This would be a call to endocrinology for me. So takeaway point is, don't forget that there's also iodine in CT contrast dye and amiodarone, and be careful about that up front until the patient's thyroid's blocked.
Lots of detail to know about iodine. The most important thing is wait at least an hour until after the thionamide to give it. And just remember that in patients who have thyrotoxicosis from amiodarone or multinodular goiter, that's when we might want to avoid iodine, and you don't want to send your patient for a CT with contrast of their entire body if you can help it.
Exactly.
All right. The last medication we haven't talked about yet are the steroids, which is something that we sometimes forget about, but is very important in thyrotoxicosis. How do corticosteroids contribute to thyroid storm management beyond just the adrenal support? And how do we give it? What do we give?
Okay, so in addition to the adrenal support, it also helps decrease the peripheral conversion of T4 to T3, and it can also help blunt the systemic inflammatory response that can sometimes co-present with thyroid storm. I will mention that the dosing is higher than we generally would give for adrenal support. Depending on which resource you're looking at, it can be as high as 300 milligrams IV of hydrocortisone followed by 100 milligrams Q8, which is more than we would usually use. And part of the reason for that is because you need higher doses in order to take advantage of some of those additive benefits for peripheral conversion.
First to know, we're giving massive doses of steroids, like not MS doses, but massive doses. Hydrocortisone, 300 milligrams IV load, and then 100 Q8H. Or the other option is dexamethasone, 8 milligrams IV. I love dexamethasone. You just give it once and then you don't have to worry.
Nice.
And then just to understand why we're giving the steroids in the first place, of course, it's the adrenal support. It also helps to block that peripheral conversion of T4 to T3, and it helps dampen the inflammation that's going on. So just to kind of review all the medications there, the best way to remember this is probably the BB-CIT. So you've got your beta blocker, which most of us will be reaching for esmolol for adrenergic control. You've got the next B, which is block hormone synthesis, and PTU will probably be our go-to there. For steroids, you can give Dex 8 milligrams IV or a big dose of hydrocortisone 300 milligrams to treat the adrenal insufficiency and also block the conversion of T4 to T3. Then you should be waiting at least an hour after you give your PTU to give your iodine, which also blocks hormone release. But remember that you shouldn't be using iodine in patients where amiodarone is the cause. And then don't forget the last T of BB-CIT is to treat the underlying trigger, for example, giving antibiotics for infection. All right. One thing we haven't talked about yet is passive cooling and also treating the agitation. So a lot of these patients will be very agitated. And in terms of cooling, it's kind of similar to hypothyroidism, where we don't want to aggressively heat up the severely hypothyroid patient. And by the same token, we don't want to aggressively cool these patients either. So, Alyssa, what are the risks of overcooling in the patient with thyrotoxicosis? Why do we prefer passive cooling?
Yeah, so these are not the patients that we're going to be putting in the body bag full of ice water like we would for some of our environmentally mediated hyperthermia syndromes. Remembering that this is a hyperthermic problem being driven by a hormonally mediated process, not an environmental one. So we need to treat that as our priority with the treatments that we mentioned above, and their hyperthermia should resolve. That being said, we will employ our usual passive cooling techniques. We want to remove our excess clothing and blankets, controlling room temperature, things like that. The issue is that if we cool too rapidly, we can cause shivering, and this might actually increase our heat production and worsen our tachycardia. We can also worsen peripheral vasoconstriction, which can worsen the patient's hypertensive crises. And there's a risk of afterdrop when the meds do eventually kick in. If your patient's cooled rapidly, they can actually become subsequently hypothermic once their thyroid issues are dealt with. There's some adjuncts that we can use that can be helpful here. For example, you can use Tylenol if their liver isn't already injured. It won't be super efficacious. We don't want to use NSAIDs because that can actually displace T3 and T4. But Tylenol is okay to use. And then benzos are very helpful for both agitation as well as to control shivering and assist with their hyperthermia. But remember, none of these strategies replace good antithyroidal medical treatments, putting the fire out at the source rather than throwing ice cubes at it.
Makes sense.
So the big thing that I wanted to add here is the benzos for agitation is key. So a couple of things about agitation that are really important. One, when you have an agitated patient, a lot of times we go to things such as your neuroleptics. And one of the big ones that a lot of people use is Haldol. Remembering that these medications can also induce the hyperagitation and make things worse, especially there are case reports of patients who get Haldol for agitation and thyroid storm and actually precipitates the thyroid storm. Similarly, there's case reports with Benadryl. So benzos are the go-to medication for agitation in patients with thyrotoxicosis. But one of the ones that we a lot of times use in the emergency department is, I'm going to say it, ketamine. We love ketamine. This is a circumstance where ketamine can actually be harmful. Because remember that ketamine does actually induce a catecholamine surge, which will make and potentially worsen your thyroid storm and can make things worse. Because of the beta receptors that are overexpressed, we are not going to give them something that can make them a little bit more hyperexcited, a little bit more hyperagitated, and a little bit more hypermetabolic. So I try to avoid ketamine in your patients with thyroid storm and stick to your benzos, your benzos, your benzos.
And now a word from one of our sponsors, Paratus, the all-new emergency assistant. Paratus combines everything you loved about Easy Recess with powerful upgrades, just-in-time procedural guidance, stress-proof organization, and Atoms, the intelligent assistant that helps you find exactly what you need. Whether you're in the ER, on transport, or in the field, Paratus keeps you ready for anything. Learn more and start your free trial today at paratusmedical.com/emcases. That's PARATUS medical.com/emcases. I want to talk a little bit more about heart failure and thyrotoxicosis. George, could you just kind of run through for us the patient in heart failure and thyrotoxicosis and how you change your management essentially from the usual that we talked about, the BB-sit? How do you change your BB-sit mnemonic when you have a patient who has both thyroid storm and CHF in front of you?
Sure. So one of the big things, as we alluded to earlier, is I'm going to use the PoCUS. The PoCUS is going to help me kind of differentiate, does this patient have high output heart failure and low output heart failure? Clinically, it's very difficult to distinguish between high output and low output heart failure unless you're really good with looking at the vital signs and looking for that widened pulse pressure that you typically will see with high output heart failure, which you won't traditionally see with low output heart failure. But clinically, they look very similar. They're going to have some element of pulmonary edema. They're probably not going to have as much on the way of, your lower extremity edema, primarily because most of these patients haven't sat in that low output heart failure for long periods of time. We have to remember the spectrum of the disease of thyrotoxicosis. Unless the patient has underlying CHF at baseline, the way this usually progresses is that these patients develop high output heart failure, that then the heart starts to get tired after pumping hard and fast for such a prolonged period of time that they end up going into low output heart failure. But again, they can start off with a history of CHF and subsequently start off in low output heart failure. It's not like the thyrotoxicosis is going to make their heart start beating harder and better, saying, oh, this is like an inotrope for patients with CHF at baseline. So in this scenario, your ultrasound is going to be the thing that helps you the most in doing a PoCUS and seeing what the echo looks like. So what I'm traditionally looking for, I'm going to do like a quick eyeball test. I'm going to look at a parasternal long view, looking at what does the squeeze of the heart look like. I'm looking at the left ventricle and saying, does that left ventricle look hyperdynamic, or does it look like that EF is a little bit on the lower side? I also will look at the apical four-chamber view to kind of get a sense of what does the RV look like as well. And that'll also give me a little bit of a sense of what the preload looks like as well. The other thing that I'll look at is the IVC. And does that IVC look plethoric with that hyperdynamic heart? That's a patient that's more likely to be in high output heart failure. Versus does the IVC, does it look plethoric or does it look like it's okay or not really full? That person more likely is going to be more on the low output heart failure side. The next thing that I'm going to look at is obviously I'm going to take a look at the lungs. Does this patient have signs of volume overload, pulmonary edema? Do they have B lines that are present? It can also help me if I'm looking for any types of consolidation to see, does this patient have maybe a pneumonia that may have thrown this patient into thyroid storm? And then once I have a pretty good assessment of is this high output heart failure versus low output heart failure, you have to understand the pathophysiology for both of these. So in patients with high output heart failure, their contractility is going to be increased, their cardiac output is going to be increased, but because their cardiac output and their contractility are increased, their systemic vascular resistance is actually on the lower side. So if you give them anything that's going to significantly decrease further systemic vascular resistance, such as giving them nitrates or significant afterload reducers, we actually are more likely to cause them to have cardiovascular collapse. So we don't want to give them anything that's going to make them have lower systemic vascular resistance versus low output heart failure, very similar to your CHF patients. those patients are going to have decreased contractility, decreased cardiac output, and their systemic vascular resistance is going to be increased. So they actually respond a little bit better to your nitrates and your afterload and preload reducers. So in terms of the management of these patients, what I'm traditionally going to start with once I've done my ultrasound, if the patient has high contractility or high output heart failure, I'm going to focus predominantly on the beta blockade to, again, try to slow that heart rate down to give their time to be more forward flow. I'm going to give them some diuresis as well. And in that scenario, diuresis is going to help offload the pulmonary edema that's present. So I'm going to start with my esmolol. If they have good blood pressure, you can start your propranolol as well. But the thing that I'm going to focus on here is that systemic beta blockade, giving some diuresis, and then continuing the antithyroid therapy, trying to get that heart rate down to a lower level, less than 110, and to help this patient get better. In the patient with a depressed ejection fraction, these patients are actually a little bit more on the scary side because, again, if we give them propranolol, we're more likely to throw them into cardiac arrest. And if you unfortunately make that mistake, there's a couple of options, which I'll talk about in a second. If you start them on esmolol, even at a lower dose, and they start to decompensate, you're going to turn your beta blockade off. And now you're going to try and primarily focus on your antithyroid therapy, your iodine, and your steroids. But let's say they need a little bit of help. Let's say that these patients have such a low EF that they're actually showing signs of cardiogenic shock. So these patients are now hypotensive. You may have to actually start inotropes. So you may need to add things like dobutamine and milrinone. But a lot of these patients are going to need further help. You're going to need to call your intensivist colleagues, maybe even need to start things like therapeutic plasma exchange, maybe even need to go all the way to ECMO to help these patients, to help their heart beat in an adequate fashion to actually perfuse the rest of the body and get them out of that cardiogenic shock. So low EF heart failure is actually a little bit more scary because the beta blockade in this scenario may be harmful and is probably going to be harmful because now you're giving them something that's going to decrease their negative inotropy a little bit more. So in this scenario, you may need to give them inotropes. And then again, you may need to call your colleagues to get therapeutic plasma exchange on board and then potentially ECMO if these patients continue to get worse. So your PoCUS is going to be your friend, and use your PoCUS to help kind of drive which way you're going in terms of therapy.
Fantastic. All right. PoCUS is your friend to figure out whether it's high output or low output. If it's high output, you're essentially going through your BB-sit, and you might add some furosemide. If it's low output, I'm calling Alyssa.
And I'm calling a friend.
Yeah. Okay. Alyssa, any comments to add about managing the patient with heart failure and thyrotoxicosis?
No, I would just say, really, really careful about making sure that you know what their contractility is like before adding beta blockers. And, the safer one to use in times of uncertainty is the esmolol with very close and careful follow-up because I think many of us have seen catastrophes of beta blocker usage gone awry and patients either arresting or going into fairly refractory cardiogenic shock.
Great point. All right. I think we're heading near the end here. I just want to summarize. There's just so many great nuances, pearls, and pitfalls that you guys have given us. They'll all be in the show notes, which I myself will definitely look at the show notes when I have a patient that I'm considering thyrotoxicosis because it's a lot of stuff to remember. But let's kind of bring it all home here. So thyrotoxicosis and thyroid storm are pretty rare but quite deadly endocrine emergencies, and they're really a clinical diagnosis. You should think about thyrotoxicosis and thyroid storm in anyone with unexplained fever, tachycardia, and altered mental status, especially if there's a history of hyperthyroidism, missed medication, recent infection, or iodine exposure. If they're crashing and thyroid storm is even on your differential, don't wait for labs, treat on spec. You need to start with a short-acting beta blocker like esmolol to control the adrenergic surge, but you're going to avoid this if they're in low-output heart failure. Follow with PTU to block that hormone synthesis, then give stress dose steroids to cover for adrenal insufficiency and to block peripheral T4 to T3 conversion. It's actually a higher dose, so hydrocortisone 300 milligrams to start. And at least an hour after that thionamide's been given, after your PTU has been given, that's when you give the iodine to halt hormone release. Don't give it earlier than that because that can make them worse. And of course, treat the underlying trigger, which is usually infection. Watch out for that atypical or elderly patient. They might not look so stormy, but still be in crisis. You can use tools like the Birch-Wartofsky score to help guide you, but don't let them delay your care. And remember that they do overcall thyrotoxicosis. When it comes to cooling, cool passively, cool gently, no aggressive cooling, resuscitate wisely, and use your PoCUS to guide your heart failure management. High output gets your esmolol and diuresis, and low output may need inotropes and ECMO. So really the bottom line is, in thyroid storm, delays can kill. Act early, treat aggressively, and save a life. Any last words of wisdom when it comes to thyrotoxicosis and thyroid storm? George?
So the big keys, especially from the emergency department perspective, is to just remember to think about it. Consider it in your patients with new onset AFib with a fever. Obviously, any hypermetabolic scenario where a patient has extremes of vital signs with altered mental status, keep it on your differential. Sepsis without a source. We talked about the elderly patients with apathetic thyrotoxicosis, so keep those on your differential as well. But the big key is to just think about it. Remember to get that TSH, that free T4. And when you get it, use your PoCUS to help kind of drive which way you're going in terms of therapy. And a big key is don't forget to treat the trigger. There's a lot of times there's going to be a trigger. Be sure to look for it, have a low threshold to treat it, especially looking for signs of infection and making sure that you're not forgetting to treat that trigger.
Fantastic. And Alyssa, any last thoughts on thyrotoxicosis?
I would just add, we don't work in silos, and different members of your team have different levels of expertise and level of clinical comfort managing rare presentations. And so don't be afraid to call for help. I have great relationships with our institutional endocrinology team, and these are always really interesting and nuanced cases to manage. And you don't need to make every single decision without support and discussion. So don't be afraid to phone a friend.
Yeah, that's a great point. I mean, we've covered a lot here. There's a lot of detail. This is a rare diagnosis. You can definitely get the ball rolling. And our job really as emergency physicians is to try and make the diagnosis, stabilize the patient, and then get them help from there. And a lot of what we have talked about is, you could argue, a little bit even outside of our scope of practice. But I think it's really important to understand all these nuances because it can change some of our early management. And the more we understand about what happens to these patients down the line, the better we can treat them in the emergency department. So thanks so much, George and Alyssa, for your incredible insights into both severe hypothyroidism and severe hyperthyroidism in this two-part series. I'd love to have you both back on the podcast sometime.
Thank you so much.
Absolutely. Anytime. 100%. Thanks a lot, Anton.
All right, just a couple last things to mention. With the release of this podcast on the EM Cases website, we're celebrating 2025 by releasing the Best of EM Cases 2025. It takes a blend of the most listens, best feedback from the listeners, and my personal favorites, and lists them for you with links to each podcast. And lastly, I'm so pleased to announce the EM Cases Summit 2026, the most interactive, knowledge-expanding, community-building online EM conference in the world. I've already confirmed some of your favorite EM Cases guest experts as speakers, and for this one, we're hoping to have even more symposiums. We're going to have one on rural EM, ED flow, AI, global EM, and simulation. So save the dates in your calendar. November 19th, 20th, and 21st, 2026. Again, EM Cases Summit, November 19th, 20th, and 21st, 2026. And if you haven't already, please do sign up for the EM Cases newsletter on the EM Cases website to get updates about the summit and everything else EM Cases. So until next time, take it easy.